Welcome to podcast 2.
My name's Fran.
And I'm Minnie.
So welcome to this series of podcasts which are aiming to bring education to you, the clinical officers, in your setting. As we mentioned before, this is a trial of educational podcast, so please give us your feedback, both positive and constructive. And also let us know if there are any future topics you'd like to be included. The forum is the best place to feedback on this. Thank you.
As we mentioned in our first podcast, with each podcast we want to give you a tip. And this podcast tip is to remember to ask specific questions which will provide detailed information about the illness and help you make a diagnosis. Remembering that in 80% of diagnosis are made actually on the history, and your examination really confirms the diagnosis that you've formulated in your mind.
Gosh, 80%, that's quite a lot, isn't it, Minnie? So that's actually very little of the examination that is kind of changing the diagnosis.
That's right. So it's really important to tease out those important factors in the history so that you can pinpoint what you expect to find on the examination.
Brilliant, that's really helpful. So on that topic, today's topic is history taking specifically around respiratory symptoms. So for a patient who presents with respiratory symptoms.
Okay, so there are some very specific symptoms that we would ask about. And Fran, do you think the most common is probably someone presenting with cough?
Yes, I think so. That's certainly my experience, and so with a cough, I'd be wanting to know a little bit about the character. So that would be whether it was dry or a wet cough, and when it occurs, because different coughs occur at different times. So,
so can you give us an example of a cough that occurs at different times?
Okay, so classically we'd think of asthma, which has what's known as a diurnal variation, which means it tends to get worse in the evening, nighttime and early morning. And so typically that's when asthmatics would be coughing the most.
Okay, so maybe someone presenting with a nocturnal cough specifically would make you think about asthma, would they?
Yeah, well, it would be there as one of my differentials. And then going back to character, Minnie, so what sort of examples would you have for that? Okay,
well, there are some very specific coughs which make you think of certain things. So if someone presents with a cough that sounds like a whoop, so they'll cough, 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 and before they catch their breath, there's a inspiratory noise, and which we would describe as a whoop. Will certainly make you think of something like whooping cough and pertussis, or any of the similar infections like parapertussis is another one that will give you a similar cough.
So pertussis is the same thing as whooping cough?
Yes, that's right. So, I mean, we've certainly seen an increase in the UK of whooping cough over the last 5 years. I'm not sure what the instance is in Zambia at the moment.
Yeah, so definitely in the UK it's been a massive problem in neonates, so newborns catching whooping cough. So in fact we now vaccinate pregnant women during the pregnancy with an additional dose of the whooping cough or pertussis vaccination to prevent that.
Interesting that you mentioned neonates, because they often don't present with a whoop in their cough. It's more that they will present with apnea, stopping breathing.
Right. So that could make it harder to diagnose.
Indeed. So moving on to other characteristic coughs, you've got your barking cough, which you get with croup.
Yes.
And then thinking about, you mentioned dry cough. We've also got productive cough, so someone who's coughing up. The cough sounds wet. They're producing something.
Okay. And when you say producing something, you mean sputum?
That's right. Yes.
Okay. So that moves us nicely on to the second symptom that we should ask about, which is sputum. So what are we asking about that?
So we want to know how much they're producing, what sort of colour it is, whether it's there all the time or just some of the time.
Okay, and so taking those individually, so if we're looking at amount, what sort of illness would give you a large amount of sputum?
Well, things that are more chronic, so bronchiectasis will produce a lot of sputum and be really quite difficult to manage for the patient. And with a superimposed infection on bronchiectasis, it'll certainly get worse.
Yeah.
What about...
And so with patients like that, then the advice that I've always been given and passed on to patients is that if their sputum changes colour from clear, which is probably normal, to coloured, so yellow or green, then that would mean that there would be an infection there, although, we wouldn't necessarily know whether that was viral or bacterial, but it would suggest that there was a super added infection on top of their normal disease process.
So it's important to take into account what is normal for that patient as well then, isn't it?
Absolutely. And I think lots of smokers will tell you that they, not in the same league as the bronchiectasis, but they will cough up a small amount of sputum every morning, and that's normal for them. Yeah.
So we've mentioned colour, but not just the sputum, but you may find that people are producing blood, so hemoptysis.
Okay.
What does that make us think about, Fran?
Well, so obviously in Zambia, TB is a problem. So I think any blood in the sputum that you'd be wanting to rule out TB immediately. In the UK, where we don't have such an incidence of TB, if it was a new onset cough with blood in it, we'd be worried about something like a pulmonary embolism, which is a blood clot in the lungs, or lung cancer. So if it was an acute thing, you'd maybe be thinking more of a pulmonary embolism, but if they've been coughing up blood for a while, you might be thinking more of a lung cancer type pathology.
Okay. So that moves us to thinking about other things like wheeze. That's another question we ought to ask, whether they are experiencing any wheeze.
Yeah. So a wheeze is like a whistling noise on an expiration. So it's like that. And you have to be very clear when you ask about it. I know certainly with my patients, they tell me they're wheezy, but when I actually get them to explain what a wheeze means, it's not a true wheeze that they're hearing. What they're actually hearing is mucus in their chest. So maybe I quite often give them, make the noise for them so that they understand what I'm talking about specifically. And I mean, the most common thing that presents with a wheeze in the UK is asthma. So that's what we would be thinking about. But you can also get a wheeze with infections. And you can sneakily also get a wheeze with cardiac problems. So
does that sounds the same as the wheeze that you obviously get with respiratory problems?
It does. So a cardiac wheeze comes when there is fluid on the lungs because the heart isn't pumping properly. So that's known as heart failure. And so you just need to be a little bit mindful, if it's a patient that's older, that maybe has a cardiac history, just keep that in the back of your head, that it might be that it's fluid there rather than an asthma type wheeze.
So all that wheezes is not necessarily asthma. That's
exactly. That's a really good way to put it. Yeah, brilliant. Yeah.
Okay. So thinking of cardiac, that makes me think of chest pain. Is that another symptom we should be asking about?
Yeah, definitely. So respiratory type chest pain tends to present very differently to cardiac chest pain. So it tends to be sharp or pleuritic. So what we mean by pleuritic is a sharp pain that is worse when somebody is breathing in and out, and that's because the pleura, the lining around the lungs, is inflamed, and that's just giving you that sensation. And so. But with pain, always you need to ask quite a lot of detail about it. Yes. So, Minnie, what sort of detail do you tend to ask about pain?
Well, you want to know how severe the pain is, as number one. And you can do this by saying to the person, is this on a scale of 0 to 10, 0 being no pain, 10 being the worst pain you've ever experienced in your life, where does this pain fit?
That's quite helpful, isn't it? Because actually somebody can look like they're not in a lot of pain, but for them, they're just managing to control it. And actually it is incredibly painful.
Well, that's right. And it's hard to know the pain that someone is experiencing for them.
Yes.
I mean, yes. with children, you can sometimes use pictures. So smiley faces, not very happy faces, and very sad faces, or a crying face. So you can use different things to get people to explain the sort of severity of the pain that they're experiencing.
And I tend to, certainly with women who've had children, I tend to use, if 10 is childbirth and 0 is no pain at all, how bad is this? And that
excellent.
gives people an example of sort of where you're at. Yeah.
Brilliant. So other things you want to know when the pain started, how long it's been there, whether it fluctuates, what helps, what makes it worse, things like that. And we'll reiterate that perhaps at the end of
and I think maybe we were going to do another podcast specifically around pain, because it is quite a big topic, isn't it?
It is, yes.
Yeah. And then, so finally, with regards to respiratory symptoms, we'd be asking about shortness of breath. So is the patient feeling short of breath? Is that at rest? Is it on exercise?
Okay.
How much? Yeah, sorry.
So when you're saying on exercise or on, how does it affect their normal daily activities? Are they still able to do the normal things that they're expected to do, or are they struggling with breathlessness? So I mean, so it may be like, are they short of breath, going about their daily business in terms of, walking distances to family members, shops, etc. Or even just, are they short of breath getting dressed? If someone has very bad problems, then, even getting dressed or washed would make them very short of breath. So those are good questions to ask specifically, actually.
Yeah. And the other thing is something called orthopnea, which is a specific shortness of breath at night where you need to sleep on a lot of pillows. So you're propping yourself up at night from shortness of breath. And that tends to be related to a cardiac problem, again, to fluid on the lungs.
Okay, so then that would lead you down to ask other specific cardiac questions, wouldn't it?
Yes, it would. And again, that's a future podcast, the specific cardiac questions that we would be doing.
Yeah. So just in summary of those, when you have asked these questions about the specific questions, any symptom that you get a positive response from, you obviously want to dig a little bit deeper into those symptoms and ask, as we mentioned before, about the onset, the duration, and how it's been fluctuating, how severe this symptom is to the patient, precipitating relieving factors, and if they've had any previous episodes as well, can be quite useful.
Yeah, fantastic. And so as we said before, the more information, the merrier, because it just helps us get a picture of what's going on with the patient and makes a clear diagnosis much easier. Mm-hmm. Yeah. And then finally, as with any history taking, you want to think about systemic symptoms. So that's things like night sweats and weight loss, which would indicate certain other illnesses. So what sort of illnesses do you worry about with that?
So we'd be worrying about tuberculosis, HIV, certain cancers, things like that, really, just that affect the whole system as opposed to just one area of the body.
Yeah, fabulous.
Okay.
And don't forget, so all of this information that you have, even the negatives, are incredibly helpful when you're filling out a case for the virtual doctor. So for the doctor, if the patient says they don't have a wheeze, actually us knowing that is incredibly helpful. So please, the more information that you can include and write in free text in the description box on the app, the easier it is for us to formulate a helpful response for you.
Absolutely. That's great, Fran. Thank you very much for that. So finally, if we could just ask you again to feed back to us on the forum about what's been good and what's perhaps needs improving, that would be great. And we'll speak to you next time, going further into the respiratory system.
Brilliant. Well, that's goodbye from me.
And goodbye from me.
Many
Bye-bye.
thanks. Bye.